wish I had someone who can help with my dreams.
Hello and welcome to the class today. So we're going to pick up from where we stopped in our last lecture. We're looking at different pathologies that is possible in the pancreas. So we'll begin with the echogenic pancreas, right? Now, the normal adult pancreas has homogeneous texture with slightly more, which is slightly more echogenic than the adjacent liver. Now, that will be if the liver does not have any fatty infiltration. So, when you compare the normal liver to the pancreas is homogeneous in texture and is slightly more echogenic than the liver. So the echogenicity of the pancreas varies with age and obesity. Children would often show less echogenic pancreas than adults. Slim adults often will have isodense pancreas when you compare that with the adjacent liver. But however, the pancreas may become highly echogenic due to physiological and pathological conditions. And physiological conditions that could make the pancreas more echogenic will include age. For age, you have older adults would have pancreas that is slightly more echogenic than their liver. In the elderly, the pancreas actually become fibrosed, and the fibrous tissue usually are highly echogenic. Other physiological conditions will include obesity. In obesity, you have retroperitoneal fat that can also influence the echogenicity. Now, the pancreas is an organ that it does not have true capsule, right? So the retroperitoneal fat may infiltrate the organ in an obese patient that will result in a more echogenic pancreas in obese people. In few patients, there may be a focal area of decreased echogenicity as compared to the rest of the gland, which is highly echogenic. Commonly, you will see this focal area of reduced echogenicity in the posterior aspect of the pancreatic head or the uncinate process, and this area will be referred to as focal fatty sparing. Especially if you have that diffusely infiltrated fatty situation. Physiological condition will also include diabetic patients. The incidence of fatty infiltration resulting in echogenic pancreas is common in diabetic patients. Now, these are images. For example, this image this shows a highly echogenic pancreas in obese patient, and you also have these heterogeneous pancreas. You see that in chronic pancreatitis. Fatty infiltration of the pancreas, and this pancreas basically looks bulky and echogenic. So this is an example of fatty sparing and the oxygenate process. And the oxygenate process has a different embryologic origin. More reason why there is that possibility. Yeah, we'll look at that in embryology lectures when we get there. All right. Non-fatty physiological conditions will include cystic fibrosis. And cystic fibrosis is an inherited autosomal recessive disorder which causes the serous and the mucous secretions to be too thick, actually, which basically will be affecting the sweat glands, the salivary gland, the lung, the liver, the pancreas, and the gut. Now, this thickened, viscid mucus that it is expressed will obstruct the pancreatic duct, resulting in pancreatic fibrosis and the loss of enzyme production. And basically, ultimately, it will lead to malabsorption since the pancreatic enzymes are not present to enable digestion in the duodenum. Sonographically, the gland is an irregular, contoured gland, is inhomogeneous in texture and highly echogenic. The pancreas is shrunken due to diffuse atrophy and fatty replacements. Its associated findings will include small incised gallbladders, which are sclerotic, or what you want to call micro gallbladder, thickened wall bile duct filled with thick echogenic bile, and a liver that demonstrates the effect of fatty infiltration and cirrhosis. This image shows you an example of cystic fibrosis in 18-year-old girl. Also, you have congenital cysts. Now, solitary congenital cysts in the pancreas are rarely seen. They're not very common. So multiple congenital cysts of varying size and shape usually will range from 3 mm to 5 centimeters. These are occasionally seen associated with cystic disease of the kidney, cystic disease of the liver, the spleen, and pancreas as part of the broad spectrum of adult polycystic kidney disorder and autosomal dominant polycystic disease. Now, this is an example of a simple cyst in the body of the pancreas. Now, in acute pancreatitis, this is actually the inflammation of pancreas due to the escape of pancreatic enzyme into the glandular tissue. Most common causes are alcoholic abuse. Alcohol alters the pancreatic enzyme concentration, which results in protein precipitations, plugging the duct. So that basically is the cause for acute pancreatitis in the alcoholics. Then you have gallstone pancreatitis, which is due to the transient obstruction of the ampulla by migrating stones and reflux of the bile into the pancreatic duct, and that portends a very dangerous situation. It's actually an emergency. Other less common causes of acute pancreatitis will include trauma, viral infection like mumps, renal transplantation surgery is a less common cause, previous instrumentation, penetrating peptic ulcer. Signs and symptoms: you have moderate to severe epigastric pain radiating to the back. So I've always tell people you cannot diagnose, cannot always say the epigastric pain radiating to the back is ulcer or gastric ulcer or peptic ulcer disease, because there is a pancreas there. You need to examine it to rule out which is which. So that usual description that I see in most results will not always be correct, because Acute pancreatitis can actually cause moderate to severe epigastric pain that radiates to the back. It also will cause nausea, vomiting, obstructive jaundice, and this actually will be due to compression effect of the distal common bile duct. You have elevated level of serum amylase and lipase, diabetes, which is the increase of blood sugar, malabsorption. Now these are also possible indications for the request for ultrasound of the pancreas. Clinically acute pancreatitis is usually self-limiting, lasting for 3 to 5 days. But in some patients, it may become protracted and is usually self-associated with elevated levels of urine amylase. Serum amylase rises very fast and then falls back very fast within 48 to 72 hours. But urine amylase will persist for 7 to 10 days. Sonographically, acute pancreatitis will appear first in the early stage. Ultrasound may be possible as the disorder is often associated with paralytic ileus that interferes with ultrasound visualization of the pancreas. And again, ultrasound may not in this case be very sensitive, so CT will be your best choice to rule this out. So the success of ultrasound procedure improves 48 hours after the acute episode, as the paralytic ileus basically would resolve. But again, CT will be your best choice. So the common sonographic features for acute pancreatitis will include size. You have enlarged swollen pancreas, and maybe focal enlargement only affecting the head, the body, only affecting the tail, or is it diffused enlargement of the whole pancreas? So these are the kind of things you see. Other features like border. You can have irregular pancreatic border. You can also have echogenicity, usually less echogenic than the normal pancreas, and maybe echogenic if there is interstitial hemorrhage. Then you begin to see increased echogenicity. The main pancreatic duct will dilate if the head or the body is involved, or it may be compressed. The dilation will be based on obstruction of the duct, and in some cases, especially in generalized or diffuse enlargement, is compressed. You have a peripancreatic fluid collection as an ultrasound feature, and may lead to pancreatic ascites. Now, if the head is swollen, there may be dilatation of the common bile duct, intrahepatic bile duct, and distended gallbladder. These are positive Courvoisier sign features of obstructive jaundice. Bile duct stone may be seen in distal common bile duct or the ampulla. Sonographic findings will vary depending on the following types. It will depend on whether it's diffuse or focal acute pancreatitis, or whether it's an acute hemorrhagic necrotizing pancreatitis. For diffuse acute pancreatitis or acute edematous pancreatitis, whichever one you choose, in mild acute pancreatitis, ultrasound will show normal pancreas with abnormal clinical and lab findings. So in this case, it's a mild acute pancreatitis. As the condition worsens, pancreas enlarge, that is, swells, and shows decreased echogenicity due to interstitial edema. The pancreas may also become inhomogeneous. The pancreatic duct may be compressed or it can be dilated. Since sonographic findings are due to edema, this form is also known as acute edematous pancreatitis. But whichever one you use, you're still correct. Diffuse acute pancreatitis or acute edematous, because of what we just explained. There is also the focal acute pancreatitis. Here you have the focal hypoechoic or isoechoic inflammatory mass in the head, body, or tail that may mimic pancreatic carcinoma. Now, if the patient is asymptomatic and serum amylase is normal, the focal mass is more likely to be pancreatic neoplasm. If the patient is having severe pain with elevated amylase or lipase level, the focal hypoechogenicity is more likely to be due to acute focal pancreatitis. In acute hemorrhagic or necrotizing pancreatitis, it is the most severe form of acute pancreatitis with focal hemorrhage and or necrosis. The escape of pancreatic enzyme may cause erosion of the small blood vessels. Interstitial hemorrhage and pancreatic necrosis is often complicated by a secondary bacterial infection on the 3rd to 4th day. The mortality rate is very high. Diffuse or focal hemorrhage increases the pancreatic echogenicity, which will give rise to swelling or enlarging of the echogenic pancreas or focal echogenic mass. Like you see in this image, here in this image you see pancreas is swollen. It's actually edematous, looking inhomogeneous, hypoechoic with irregular border. Then you see the free pancreatic fluid collection. Then in this case you have the inhomogeneous swollen pancreas with extra pancreatic soft tissue edema that is caused by an obstructing bile duct stone. Now, in chronic pancreatitis, this is the chronic inflammatory disease of pancreas that is characterized by progressive pancreatic damage with irreversible fibrosis. Acute pancreatitis seldom results in chronic pancreatitis, though many patients with chronic pancreatitis have recurrent episodes of acute pancreatitis. Chronic pancreatitis appear to be a separate entity. Most common cause of a chronic pancreatitis, again, alcohol abuse, biliary tract disease, and other. So why do we take alcohol? Anyway, it's a lifestyle issue. So alcohol and biliary tract disease are the issue. But a lesser common cause will be autosomal disease, cystic fibrosis, and sometimes unknown cause, idiopathic, right? Because signs and symptoms of chronic pancreatitis may present with mild, moderate, or severe upper epigastric pain, may be silent until the patient develops pancreatic insufficiency like malabsorption or diabetes mellitus. The recurrent inflammation will result in fibrous tissue replacement of much of the pancreatic acinar tissue. In the early chronic pancreatitis, there may be elevated serum amylase and lipase. But in the late chronic pancreatitis, after a widespread destruction of the acinar glandular cells, there will be decreased level of serum amylase and lipase. Sonographically, in the early chronic pancreatitis, you see diffuse enlargement of the pancreas with an increase in echogenicity and coarse echotexture. Calcification are often present both within the duct and throughout the the tissue with or without posterior acoustic shadowing. Acute on chronic pancreatitis shows scattered hypoechoic foci of residual active inflammation that is adjacent to the hyperechoic foci caused by fibrosis, and fatty replacement and calcification of chronic pancreatitis. But late chronic pancreatitis is associated with small, shrunken, irregular, highly echogenic gland with dilatation of the pancreatic ducts, which may become tortuous. Greatly enlarged or you have a greatly enlarged or dilated ducts that are more is more of a feature with chronic pancreatitis due to the combination of glandular atrophy and ductal obstruction from stone that is formed by the pancreas. Often the duct has a beaded appearance to focal strictures and dilate. You have a focal stricture and focal dilatation, forming segments of striction, dilatation, friction, dilatation. Dilatation of the common bile duct due to inflammatory strictures and the postsplenic vein thrombus. Chronic pancreatitis with duct dilatation vis-a-vis pancreatic carcinoma. Now, when you differentiate between chronic pancreatitis with ductal dilatation and pancreatic carcinoma, it's actually often difficult. In general, chronic pancreatitis is more likely to have ductal dilatation due to ductal stone. Pancreatic carcinoma is more likely to have ductal dilatation due to an obstructive mass lesion. So you will be able to have a due diligence to differentiate which is causing what, and but it's also difficult to do that. So look at this image. You see a chronic recurrent pancreatitis that results in fibrosis, which may progress to calcification within the parenchyma. There you can see the pancreas and see areas of calcification. Then in this other image, you see a dilated pancreatic duct, very significant, which is secondary to the past history of obstructive pancreatitis. Here you have a chronic calcific pancreatitis. You have multiple shadowing of calculi, which you see there. Then in this case, you have chronic pancreatitis that is scattered with small calcifications. Here you have pancreatic duct calculus without significant pancreatic dilatation. Then in this case, you have multiple duct calculi with pancreatic duct dilatation in a patient with chronic pancreatitis. And so the complication of pancreatitis, usually you have pancreatic effusion, that's to say peripancreatic fluid collection and pancreatic ascites. You have pancreatic pseudocyst, these are complications, pancreatic abscess, splanchnic vein thrombosis, splanchnic pseudoaneurysm, gastric outlet obstruction, and you have GIT hemorrhage. So in the next lecture, we'll begin to discuss some of these complications. Until the next time I come your way again, keep learning ultrasound.
I wish I had a friend helping me grow in every way, saying yes.